Welcome everyone to our webcast on growth and success of accountable care organisations in the US from 2010 to 2016. My name is Niamh Lennox-Chugani and I lead Optimity Advisors NHS and local government work here in the UK. I'm delighted to welcome today Dennis Horrigan. Dennis is an Optimity Advisors Senior Advisor in the US and is going to share his years of experience as the former CEO of a successful accountable care organisation in the US. Welcome, Dennis.
Thank you. To provide some foundation to accountable care, I want to briefly talk about the US healthcare system. It's currently a public-private system. About 36% of all health expenditures come from the government to pay it to providers, either through Medicare program or Medicaid. And the other 64% comes from the private system, which is essentially an employer-based system. We spend over $3 trillion in healthcare, and the average cost per beneficiary is about $10,000. I've been told that at the National Health Service England, that number is a little bit less than $4,000 per beneficiary per year. Estimates in the US are that somewhere between 10 and 30% of the expenditures are either unnecessary or wasteful, and we're going to talk about that. Our system is very market-based, and if you're in the private system, it's every man for themselves. You have to find the proper insurance, and you can choose from either high deductible programs or policies that cover almost first hour. Recently, we've seen increased costs across the board, both from the government side and the private payer system. We're seeing increased consolidation with hospitals purchasing doctors and doctors horizontally integrating with other similar specialties. So with this foundation to accountable care, let's just talk very quickly about what we've tried. And in 1970,
Thanks, Dennis. That's really helpful context for particularly for our non-US listeners. And for those non-US listeners, can you tell us very briefly, what is it that accountable care organisations are, and why are they seen as the answer to these challenges in the US and now more and more here in the UK?
So the history of the accountable care organization actually goes back to the work of Sidney Garfield, who was a physician who basically established prepayment for the workers in a government program to bring water to Southern California. And back in 1933, he was paid 5 cents per worker to set up a hospital. That work essentially was foundational to Kaiser Permanente. The next important person in the ACO foundational work was Paul Elwood, and he was determined and basically the father of the HMO movement and advised President Nixon. And then finally, from the Dartmouth group, we have Elliot Fisher and Jack Wenberg, who essentially coined the term accountable care organizations, and they deemed them to be an approach to manage payment to healthcare providers, and it was based upon their understanding that there was great variation in the US healthcare market, and that if providers could develop the proper processes, use technology, and use key processes, they could drive a lot of the variation away and have savings. So the accountable care simply is a group of people working together, and they're accountable for both cost and quality. The accountable care organization that I led for 10 years was essentially organized by private practicing physicians. We had 4 hospitals, home health care, long-term care, mental health services, etc. And the work of an accountable care organization essentially is to increase access, improve coordination, and work to provide better care at lower costs. So how does this work? How does an organization in the United States with private practicing physicians or employed physicians, for that matter, develop an ACO? What are the steps? Well, the first step is patient attribution. And the way this essentially works is a private or public payer looks back to its history and determines which patients were treated by which primary care patients. It then is able to attribute those patients to an ACO, and that ACO has those primary care doctors as members. The second step is the CMS or the private payer will look at historical costs for treating the group of patients that are attributed to the ACO. And those projected costs are adjusted based on demographics, both age, gender, and severity of illness. The next step is that once the patients are attributed, a budget is set based on historical costs. Then the ACO must make the improvements in care coordination, integration to reduce the gaps in care. And with the work that we've done, the gaps in care are essentially, can I get to see my doctor in a timely way? Once I'm seen, do I receive the preventive health services that are necessary? If patients have chronic illness, are they properly managed? Is there proper coordination among and between the primary care and the subspecialists and the surgeons and the diagnosticians? And that's really the magic of the accountable care organization. If at the end of the year the actual medical expenses are less than what was projected, there's shared savings. And the question then is, how are the shared savings distributed between the payer, either the government or the private payer, and then how does the ACO distribute its savings to its members? So patient attribution, let's start with the attributed patients. And if you follow the arrow that says premium up to payer, all patients or members who have health insurance pay a premium. Even if you're with Medicare, there is a Part B premium that is paid. The payer then contracts with an ACO, as I've mentioned before, based upon attributed members and a budget. And if we go back to attributed patients, as I mentioned, the attributed patients are attributed to the providers based on their historical experience in taking care of those patients, and it's usually through the primary care doctor. So if your doctor was part of ACO-A, then you would be attributed to that ACO along with your expenses. So that's the way attribution works. Sometimes attribution is based upon the patient's selection of a provider. Other times it's attributed based upon the majority of your services were provided by that provider. So how does the cost benchmarking or budget get developed? And as I mentioned, the payers look back at their claims expense. And these are claims for hospital, physician, physical therapy, pharmacy, ambulance, emergency room, etc. And for each member, they determine the claims expense, and then they aggregate the total membership and actually provide a budget for the ACO. And as I mentioned before, this budget is the basis of the reimbursement model that would enable providers to achieve savings if their expenses come in lower than the budget. So the benchmark is essentially the budget, and it's based on historical claims from the attributed population. So the next part of the ACO model is the care interventions. And as I mentioned in some of my opening remarks, the health science experts in the United States have said somewhere between 10 and 30% of total expenditures are either unnecessary or wasteful. So the question is, how do you basically provide better care at lower cost and create the interventions that are going to create these efficiencies? And essentially what the strategies have been is to use the basic principles and practices of public health. So early identification, good preventive services, good coordination of care, and most significantly, vastly improved care to patients who have high burden of illness, patients with multiple diagnoses and complicated problems. So what most organizations start with is identifying the patients who have the greatest need. And generally this is done through registries. So at Catholic Medical Partners, we developed registries for congestive heart failure, diabetes, COPD, cardiovascular disease. And what we would ask the providers to do is essentially to provide extra oversight and service to this population, because it's this population whose costs essentially drive a majority of the healthcare expenditure. The important thing about that experience is we started out with paper registries, and then we migrated to the use of the electronic health record, and that enabled us to develop electronic registries with reminders that would help the doctors and nurses in the office to know where the gaps of care are and to make those interventions at the point of care. Additionally, we would provide the doctors and hospitals with total cost of care for each doctor who is part of the ACO, so that they could determine how their cost of care for their population compared with their peers and with the budgets that were set. And once we started doing this, we found a lot of variation in emergency room utilization, in avoidable admissions and readmissions. So part of the processes that we developed is we used a rapid cycle improvement method to engage the practices in ways that they could identify patients who are at risk for hospitalization, extra assistance for people who were hospitalized that were at risk for readmission, and also additional assistance for patients that might access the emergency room rather than the practice. And that was a key intervention that we made, based upon looking at total cost of care and the frequency and cost of the populations treated by the providers. Each ACO across the country, it has different interventions, but basically they're focused on prevention, early detection, and treatment. And I would say every ACO has programs to reduce unnecessary admissions, reduce readmissions, and that's where we currently are. On the private payer side, the cost of pharmaceuticals in the past year has gone up 12%. So for those ACOs that are working on the commercial contracts, the pharmacy control is a major issue. So if you make $1 with an ACO, how do you share it? And generally, the arrangement with either the federal government or the payer is that if you make $1, the payer receives 50% and the ACO receives 50%. Some of those percentages are changing, and the way that this dynamic works is the more downside risk you take, the more upside savings you can receive. And I'll talk more about that shortly. Within the ACO, if the ACO makes 50 cents, but let's say they make $10 million, generally the ACO would share between 30 and 50% with its hospital partner. And you might find that surprising, but a hospital partner in an ACO has to set up mechanisms to reduce unnecessary admissions, ensure proper discharge, and referral to low-cost settings. So a strong hospital partner is critical. The other 50 to 70% of the 50% goes to the doctors, and essentially about half of that goes to the primary care physicians, that is those providers who had attributed members. The next biggest percentage goes to the internal medicine subspecialists who are key to managing chronic illness, and then to the surgical specialties, and then to the strictly community providers like dermatologists and ophthalmologists. So in the US, there are different models for the ACO, and these models are, I would say, developmental. And what I mean by that is each model has greater opportunity for savings and greater risk of loss. In the shared savings model, basically the majority of shared savings ACOs were upside only, meaning that they could receive surplus sharing dollars if they achieved the target performance, but there was no downside risk, meaning you didn't have to pay the payer back. The Pioneer ACO was I guess a much more demanding model in that if you lost $1, you would have to pay 50 cents back to the government. Or if you lost $10 million, you might have to pay $5 million back to the government, which creates a whole different financial requirement for the ACO. There was also an advanced payment model, which was discontinued, and now a new generation ACO model, which, as I mentioned, offers greater percentage of shared savings, but also greater risk. And what's interesting about this model is the provider, the ACO could go at 100% risk, so the government or the payer would pay the entire healthcare premium to the ACO, and then they would have to set up mechanisms to pay the hospitals and doctors. Another component of this, less demanding, is the ACO could actually say to the payer, pay me only 90% of my fee schedule and give me the 10% in cash so I can support the infrastructure of the ACO model. But when things are reconciled, there was no payback in that model because you've actually discounted your fees to receive basically developmental money to establish your ACO. And then finally, sometimes what the payer will do is to provide a care management fee, a per member per month fee for each member enrolled. And with the next generation, I believe it's $6 that each primary care will receive to take care of the population. But when things are reconciled, if the budget is not achieved, then that $6 would have to be paid back. So you can see that the next generation model has different choices depending on how mature and how competent your organization is.
Thank you, Dennis, for explaining so clearly and simply what is obviously a very complicated and constantly evolving system in the US. My next question for you is really, what impact and what changes have you seen in the ACO market in the time that you've been involved? Obviously, you've talked a lot about the changes that you experienced at Catholic Medical Partners, but what about the marketplace as a whole? How has that changed?
We were, at Catholic Medical Partners, we began in 2012 and with our federal contract, which is a shared savings contract. Previous to that, we had 5 private arrangements or private ACO model contracts. And what we've seen, we were what's called an early adopter of the model, and it was very interesting because with our board and our hospital leadership, they would say to me, Dennis, we want to reduce hospital admissions and reduce emergency room admissions, and the surgical specialists would say we want to reduce unnecessary surgeries, and the radiologists would say we want to reduce unnecessary radiology work, and they'd say we're shooting ourselves in the foot here. So that was very challenging, but I think to the credit of our leadership, they basically saw what was coming, and we entered the Medicare shared savings in April of 2012. And you can see from the slide here that there's been an incredible acceleration of ACOs. And what's interesting is some of the early ACO development was really based upon doctors, integrated groups of doctors coming together, primaries and specialists, to do this work. The next group were the hospitals, and as you know, probably from reading about the U.S. healthcare system, many of the hospitals in the United States have consolidated, and they actually have employed physicians, so they were structurally well organized to manage an ACO. And also some of the payers established ACOs, not only for their commercial business, but they provided the infrastructure for a group of doctors that wanted to participate with CMS in the shared savings program. So you can see that the growth of the number of ACOs, both with the federal government, has been contagious, because now more of the ACOs have multiple payer contracts. And I think all of the health plans in the United States now are trying to figure out how do you establish contracts for the ACO model, for their insurances, which is another complicated discussion that we can talk about. And when I say it's complicated, what I mean is if you're a doctor and you have multiple arrangements with a health plan, you may have different budgets, different quality indicators, different requirements for success. And what we're hoping in the United States is that the health insurance companies will pretty much replicate many of the quality and utilization requirements that the federal government has set forth, because they make perfect sense, and they're based on good evidence-based medicine, and they really deal with many of the major gaps in care. So if you look at a map of the United States, you'll see the number of ACOs, and you can see they're pretty much dispersed in the Northeast, Southeast, the West, and in Texas. Interesting, it's only a small percentage of the population in each of those states, but I can report that we see more and more organizations wanting to tackle the ACO model, but they haven't quite built the systems that will enable them to be successful. So there's a great deal of assistance going on, working with different provider groups, whether they be multi-specialty groups or hospitals, to develop the infrastructure for a successful ACO. So the, as you may know, the CMS, which is the Center for Medicaid and Medicare Services, is essentially wanted to move payments away from fee-for-service to what we call a value-based system. And the goals for the United States are to get value-based payment for all providers, and I believe it's 50% by the end of 2016 or 17, and then it moves all the way up to almost 80%. Now the question is, what is a value-based payment? And we're going to talk about that in a little bit. But the research would suggest that the ACOs will cover about 72 million people by 2020, which is just 4 years away. And as you can see from the slide, only about 23 million are covered now, and 7 million are with the federal program, which means this whole model has become contagious, and it's being used both by the government and by private payers.
Thank you, Dennis. I just wonder as well, though, I mean, we've talked a little bit about growth, we've talked about the changes in terms of processes and what it's meant for physicians. What has been the impact, though, on quality and on cost, and have there been tangible, measurable impacts in those areas to date?
So this particular slide shows the savings from the federal or the public ACO, and you see in 2013 it was 383 million, and then that increased by 2.1%. Now, this looks very favorable, but I do want to report that of the ACOs that reported savings that resulted in shared savings, only about 25 to 30% of the ACOs were successful. And there's a fair amount of detail around that, but the ACO had to save, there was a minimal savings rate, so you had to save, based on your membership, 2% in order to actually have shared savings. So if you only saved 1.5%, there would be no savings, but that 1.5% are in these numbers. So the other analytics that are going on is because the Pioneer ACO model was the first ACO model that emerged from Washington. There's comparisons between the Pioneer model savings and the MSSP, which are the shared savings. And you can see the savings rates here, years 1, 2, and 3 in the comparisons. I think that the Pioneer ACO model started off very rigorous, and there are about a third of the Pioneer ACO model participants dropped out. So I think what you see is favorable results, on either model. And with the next generation model, these numbers should look real interesting in the next 3 or 4 years. Now, I would say that these are very aggregate numbers, but if you wanted to think back to what I said about the experts have said that between 10 and 30% of the U.S. healthcare expenditures are either unnecessary or wasteful. When you look at this, most ACOs that saved probably saved in the neighborhood of 4 to 6%, nowhere near the 10 or 30% that people have projected. In year 1 with Catholic Medical Partners, we saved 12%. We are one of the highest performing ACOs in the country. In year 2, our benchmark dropped significantly, and while our expenditures went up 1% for that year, we were not under our target, and we didn't get credit for that year 1 savings, which is being remedied in the new program design. But this is difficult work, and if you remember that while the savings look very positive, only 1 in 3 were successful, and the savings rates were around 4 to 6%. And just to give you an idea, it would be 4% of about $1,000 per month. So that's the way that this kind of works. So that would be a $40 savings per month that would then be distributed and shared. So whenever you think of savings, you have to say how much can you save per member per month, and then you can forecast how much will go back to the payer, how much will go back to the hospital partner and the doctors. And the quality improvements, I haven't mentioned this, but if you save $1 or you save $10 million, you have to achieve quality metrics. And so if you save $1 and you hit 85% of your quality, then you only receive 85 cents. Likewise, 10 million, you get 8,500,000. And the quality measures are very rigorous, and they require the ACO will get a random sample of 450 patients for each measure. And what has to happen is the ACO has to go out and produce the electronic health record documentation that a person has had their immunization, their mammogram, their colorectal tests, that they've been screened for tobacco, that they've been screened for high blood pressure, etc. So it's called GPRO, is the method of evaluation that's used. It's very complicated, and what's interesting is some of the early ACOs were not successful in reporting quality, and some of those ACOs had savings, but they lost everything because they couldn't produce quality. So this is key in this model to be able to understand the systems you have in place to measure quality and to provide feedback. Now, the strongest improvements here, I can't quite account for this, but they do vary. The clinician communication, which is a survey that the patients receive, that produces that ranking as well as the rating of their doctor. Screening for tobacco cessation, screening for hypertension are measures that are that come from the electronic health record screens. And on the Pioneer Med reconciliation, which is a major issue as patients are admitted and they're discharged either to home care or nursing home and back to their primary care doctor or specialist, the amount of reconciliation is significant. What's interesting is the average Medicare patient is probably on 4 to 6 medications, some as much as 10. So this is a process that is very difficult on the provider network. Screening for depression and follow-up is another improvement, and at Catholic Medical Partners we actually built in depression screening tools for the doctors and set up systems when patients were identified they could be referred with easy access appointments. And then the qualification for the electronic health record incentive was another improvement made at both sides, and that doesn't surprise me because of the meaningful use incentives that were provided.
Thank you, Dennis. And again, I think probably as you were talking, a lot of our UK listeners were probably finding a lot of what you were saying resonated for them, certainly in terms of how complicated it is to measure quality and set it alongside cost. Well, a lot of what you are measuring in terms of quality is very similar to what we're trying to measure here in the UK. So I guess my final question to you is really around what you see as the future for clinical integration and cost containment in the US, and also what do you think some of the parallels and some of the lessons we can take here in the UK might be?
Great question. Healthcare expenditures are about demographics and the number of people that are aging, because we know as people live longer, they encounter more challenges to their health care. So you see here the trends for the population over 65, both for the National Health Service England and for the United States. And I was looking at some data the other day that showed in the US system the trend per beneficiary is up about 5% for Medicare. And of course, there's thousands of people joining Medicare every day. So our challenge, and I think the challenge you're going to have here with the National Health Service England, is you have more people aging, and at the same time you have an increasing trend in taking care of individuals. Now, in the United States, what was just passed is something called MACRA, which is a Medicare Access and Authorization System, which essentially is a complicated formula of carrots and sticks to actually stimulate improvements in healthcare, both in terms of cost and quality. And I'll try to explain that as simply as I can in just a minute here. So, just to preface this, some people have said that improving healthcare is just a matter of creating the economic model. So for years and years we've had carrots and sticks. If you hit certain metrics, you get a little bit more, and if you don't, you get a little bit less. And what we found, at least what I believe, is economic incentives are necessary, but they're not sufficient, because I've experienced hundreds of physicians, some of them my good friends, that want to do the right thing, but they don't have the system set up to do it, and they're penalized in the systems we have. As I mentioned before, every health plan, every private health plan has a series of incentives, and the doctors may have 4 or 5 different incentive systems that they have to report to, and it really frustrates them. But what's happening now is the government is taking the lead with MACRA, and there's essentially 2 tracks and that are going to be developed. The first is called MIPS, or Merit-Based Incentive Payment System, and this is for the doctors who receive fee-for-service payment for Medicare through the fee-for-service program, not Medicare Advantage. And starting in 2017, the physicians will have their quality reviewed in comparison to their peers. They'll have their resource use, which is total cost of care, reviewed. they will be working to, those two areas are going to be challenging for doctors because some doctors don't have systems in their office to understand their quality. In fact, one of my famous questions when I work with doctors is, how well do you treat hypertension? And everybody tells me we treat it pretty well. They don't exactly know the number. And in the future, how well you treat hypertension or diabetes will be the basis of either receiving an incentive payment or losing reimbursement from Medicare. So in 2019, there's a plus 4% increase you could receive, or you could lose 4%. On resource use, or total cost of care, the doctors clearly have no idea what the total cost of care is with their patients because they don't receive the claims. So this is what everybody is trying to now plan for, and the provider groups are asking the private health insurance companies, what is my total cost of care and how do I compare to my peers? So the quality and resource use will account for 60%, I believe, of the scorecard. And then advanced care information, which essentially is how well you use your electronic health record, which will mean you have reminders, registries, are you interoperable. And then clinical practice improvement activities, which I believe there will be a series of categories that you can check off and get credit for. But this is a carrot and stick system, and it's budget neutral. So the physicians who are receiving 4% are offset by the physicians that are losing 4%. So it will be very competitive. And we think a lot of the independent doctors in the United States may kind of decide to leave private practice and work for a larger system so that they have support for this. The second method is what's called alternative payment, and this is really what we've been talking about, the ACO model. So for those doctors who are in organizations like Catholic Medical Partners or other integrated systems, their payment will, there'll be no reduction in their payment. They'll actually receive an increase because they're part of an alternative payment model. And as I mentioned before, this is all directed at reaching the goal of increasing value-based payment in the United States. And as you can see, it's carrots and sticks. It's all the right measures, and it really is stimulating much more consolidation and integration, and much more focus on how do you use clinical integration, how do you bring people, technology, and improved processes together to manage a population and to achieve the cost savings. And we've mentioned, these numbers of 10 to 30% of savings. No one's hit those kind of numbers, but there is lots of evidence that in the early years, 3, 4, 5% savings is possible. And if you're managing 500,000 patients and you have $1 billion budget, 4% is significant savings to distribute within the network. So that's called MACRA, and it kind of gives everyone an idea of where the United States system is going, and it is following the lead of CMS, the federal system, which is kind of interesting because the United States has a market-based program, but from my experience, Medicare has really taken the lead. Now, the other side of federal spending is Medicaid, and the Medicaid programs are doing very similar things. So there's MACRA type systems in place where providers receive additional incentives for hitting certain metrics, and there's also alternative payment models that doctors are part of. So if we look forward and we look at some of the similarities between National Health Service England and the United States, it's really better care at lower cost. And the playbook is really driven by the principles of public health and clinical integration, prevention, early detection of treatment, caring for people who have the highest burden of illness. And at least in the United States system, as I mentioned, Elliot Fisher, who is really the person who named accountable health organizations, he and Jack Wenberg, this is very much of a reimbursement method. And when we went to Washington, when I was president of Catholic Medical Partners, it was very clear when we met with the officials that they said to me, Dennis, this is a payment model, and we can no longer make increases in fee-for-service just because of the forecast of the insolvency of Medicare, not to mention the challenges of Medicaid. So this was also very interesting for the doctors because historically they were incentivized for quality, not ever for managing costs. Now this is new, and whenever in the United States you talk about providers managing costs, the consumer organizations look at, well, if you're going to reduce costs, are you going to reduce quality? So the nice thing about all of these models is that it balances off both cost reductions with quality. And if you make $1, but if you don't achieve your quality metrics, you receive nothing. So that, I think, has the right balance.
Thank you, Dennis. That was all really, really interesting. And I think there are clearly a lot of lessons that the place that NHS England is in at the moment and the English healthcare system can learn a great deal from the US. And I think we probably have been taking on board that learning, particularly over the last couple of years since the 5-year forward view came out. Thank you again for your time and for battling allergies in the middle of that. Thank you very much. And what I would say to anybody who's listening to this webcast, if you would like to hear more, then please do go to our website, optimityadvisors.com. We have a selection of webinars, including some additional webinars with Dennis Horrigan himself on our website, as well as a selection of orange papers looking at the lessons learned from the American system, particularly focusing on accountable care organizations and person-centered medical homes, which are the US version of multi-specialty community providers, part of the new models of care program here in the UK. So again, I'd like to take a moment just to thank Dennis for his time. I hope you have all enjoyed listening to this webcast, and as I say, if you would like to hear more, please do go to our website. Thank you.